regulation from the UK Statistics Authority, Ed Humphreys, for making the time to appear before us today. To begin with, please could I ask our witnesses to introduce themselves for the record, starting with Professor Diamond.
Good morning, Chair. I'm Ian Diamond and I'm the National Statistician.
Good morning, Chair. I'm Ed Humphreys. I'm the Director General for Regulation at the UK Statistics Authority and Head of the Office for Statistics Regulation.
Thank you. Now, Professor Diamond, I know you were appointed as the National Statistician last October, and normally this committee would have held an earlier evidence session with you to ask about your priorities at the time, and that session would cover the full range of responsibilities. However, first with the general election, and now with the unprecedented crisis in which we're meeting, that hasn't been necessary, being possible. So therefore, we're going to entirely focus on COVID-19 today. Now, members of the committee have agreed areas for question. I will be starting and then I'll be passing over to Jackie Doyle-Price. So to begin with, please could you tell the committee what your respective roles are and explain how you help the government and the country understand COVID-19. First with Sir Ian, please.
Thank you very much, Chair. Well, my role as National Statistician was originally called for by Churchill in the Second World War, when numbers were coming in all kinds of directions. And Churchill took a view that there should be someone who was prepared to, if you like, advise on what the most appropriate number was. And I take that role very seriously. I also, though, as head of the Office for National Statistics, have a very important role, I would suggest, in the Office for National Statistics, really preparing data and statistics which enables government to understand society and to understand the economy. Given, Chair, I think we'd all agree that society and the economy are always changing. This means that we at the Office of National Statistics have always to be changing. And I think the role at the moment is about enabling government data to be produced in a timely and efficient way, and doing so using an ever increasing number of data. I also have a role as head of the Government Statistical Service, so therefore a role in ensuring the careers of statisticians right across government, and also head of the analysis function for government, which brings together not only statisticians, but social researchers, economists, actuaries, geographers, right across the government arena, and therefore a role in providing evidence at all stages for government. You asked, Chair, about COVID, and I think COVID is I mean, it's a dreadful pandemic, but it is a good example of what can be done. And so as soon as it became clear that this was going to be a very serious pandemic, we were able to stand up a number of things very, very quickly. So we have, for example, a survey which goes out every week, which enables to get understandings of how people are feeling about government policy, for example, the lockdown, as well as to understand adherence to it. We have been a very large business survey to understand how business is reacting. We've been using new data to inform government about adherence to the lockdown and other areas of government policy at the moment. And at the same time, we have very recently stood up a very large survey which is going to be the main way in which government measures prevalence of COVID in the population at a national and indeed regional level, and also helps to measure the rate of transmission. All those things, Chair, are new data, new surveys which have been stood up in a very short time, while at the same time really maintaining business as usual, if I may say so. For example, making sure our deaths data are timely, and we are doing analysis of them to understand more and more of the factors driving them. So you may have seen the piece we put out this week on occupation and COVID deaths, and at the same time really working to make sure the government has information on the economy. I am conscious, Chair, that is a long answer to a beautiful and short question, but the amount of work that is going on in the Office for National Statistics in response to COVID is, I think, as unprecedented as the pandemic in which we find ourselves is. Thank you.
Thank you, Ian. Ed, please.
Yeah, our role at the Office for Statistics Regulation is really very simple. We're here to ensure that statistics serve the public good. Heavy emphasis there on the public having access to information that is trustworthy, that is high quality, that is valuable in the sense that it answers the questions that they have. And we do that all the time. We do that through setting a code of practice, and we do it through enforcing that code of practice. During the pandemic, it's, I think, really been abundantly clear that it's never been more important. The public has never had a greater appetite for information, for facts, for understanding, for insight. And our role has been to support and enable producers of statistics to get the information out into the public domain. But also our role is sometimes have been to encourage better presentation, the addressing of gaps, highlighting scope for improvement. We've been reacting to all those areas. I think we've seen improvements. I think there's scope to improve further as well.
Thank you both. I just wondered, please, could you talk us through yesterday's mortality data? What does it tell us about the spread of COVID-19 and where we are in relation to the peak of the pandemic? Ian, please.
Well, I think we are, I would say, through the current peak. I mean, it does seem to me we need to be worried as a nation that as we come through this current peak, we do not seed another one. And I also think our data shows the extent to which we have a number of epidemics, an epidemic in the community, an epidemic in care homes, an epidemic in hospitals, for example. And we need, I would suggest, to be able to be prepared to act in each of those areas. And our data then also shows, if we look simply at excess deaths from all-cause mortality, it shows the extent to which it is not only COVID direct deaths that are a challenge at the moment, but also that there are deaths which, if you like, you could call being indirect. They're not due to COVID, but they have been caused, for example, due to other causes which may have resulted because of, say, reprioritization in the health service. And what we're seeing, I think now, is a reduction in the deaths in each of those areas, but not at the moment as speedy as we would perhaps like.
Thank you. And Ed, from your point of view?
Well, I think what the figures published yesterday show is that the producer of statistics, ONS, responding to the demands, public demands for information, for example, by giving much more detail about care homes, what's going on in care homes, and also by some of the supporting information. Sir Ian referred to what came out earlier this week on occupation patterns by occupation. I should also say, of course, it's not all about the ONS. The weekly death figures are also published for Northern Ireland by the Northern Ireland Statistics and Research Agency and by National Records Scotland for Scotland. I think they're equally commendable for the comprehensiveness of the figures they produce.
Thank you. Just before going to Jackie, David Jones, please, with a supplementary question.
Yes, please, Chairman. Professor Diamond, you mentioned that there were effectively 3 epidemics at the moment, one in the community, one in care homes, and one in hospitals. You probably will have seen the report from Oxford University that came out a couple of days ago, which suggested that whilst there may be said to be an epidemic in hospitals and care homes, there was not one in the wider community. What are your views on that?
Well, my own view is that we certainly do have an epidemic in the wider community, but it is one that both has caused death, no question, in my view, but equally there are a very, very large number of people still in the community who have COVID. Our data on prevalence in the community published on Monday show that we estimate that around about 136,000 people in the country have COVID at the moment. And that suggests to me that there is an epidemic in the community.
Thank you, David. Jackie Doyle-Price.
Thank you, Chairman. Professor Diamond, could you give a brief overview of data sets available to the government in making decisions about the response, and really give us a view about the relative merits of each data set?
The response to the COVID pandemic?
Yes.
Yep. Okay. Well, there are a very, very large range of data sets. So, as I indicated, there are data from DHSC, which include hospital admissions, which include death data there, data from the Care Quality Commission. We produce data both on deaths, but also on the characteristics of people who die. We also have a lot of data on adherence to the lockdown, and we also have a lot of data on the economy. And with regard to which ones work, let me just take an example of death data. And here we have an interesting challenge. The ONS data are unquestionably, I would suggest, the most comprehensive. But because they're based on death certificates, and because we can only put them all together when the death certificates have come in, then clearly there has to be a lag. And we have a lag. So we, for example, yesterday produced data for the week before last, so to speak. Now, clearly, government also needs timely data, and the data that is produced by DHSC has, I think, been improving greatly over the course of this pandemic, and now does include all deaths that are recorded on a particular day and which have a positive test for COVID, whether they are in care homes or they are in hospitals. Still, though, they will have particular lags around them. So every weekend we see a reduction, and that is because hospitals don't report so often at weekends. So what we need to do, and I think what government does very well, is to produce moving averages so that you get a sense of the trend. And in summary, on those particular data, you have, if you like, the comprehensive data from ONS, which includes not only positive tests for COVID, but also those where the practitioner thinks that it was COVID, but they don't necessarily have a test, and which may be the primary or the secondary cause. And you compare that with, if you like, the more timely deaths. I think, personally, both produce information which government should be using.
Thank you. Ed, do you have a view on the relative merits of the data we're using?
I completely agree with Professor Diamond here. It's a case of balancing what provides kind of leading real-time indicator, which is the daily figure, with the much more comprehensive figure that comes out on a weekly basis. I think right at the start of the pandemic, there was a danger that the daily figure was presented, so to speak, nakedly, just as a number, and without recognizing whilst it's timely, it has these limitations, these incompletenesses. And in fact, it was even more incomplete at the start because, as Professor Diamond has said, it didn't include anything other than deaths in hospitals for the most part. But that presentation of that figure has consistently improved. It's gone to all settings where there's a positive test and death now. So that's more comprehensive since the 29th of April. And the explanations around it are now much clearer that it is a more limited measure than the weekly ONS measure. So I think the way to think about this is you get an incomplete but timely figure through the daily number, and then a more complete but slightly lagged measure through the ONS figure. And the key is not so much to say, well, which is better and which is worse, but what's the one which best answers the need that the question you're trying to answer. If you want to figure out what's going on right now, you go to the daily. If you want to think about what's a more complete and comprehensive picture, you go to the weekly. And of course, the second key is that the people presenting those data explain those factors very, very clearly. And so there's no room for doubt as to which number is being used in which context.
Yes, context being all, and actually your data shows the direction of travel in any case. But it's an interesting observation that, you know, that putting that naked figure out is as much part of the messaging that government needs to do around this, and that drives people's behaviour and response. Another question to Sir Ian. You told the Science and Technology Committee that data used by the government in the daily briefings was statistically sound. And we've heard from both of you about how that's been improving over time. But would you say, how accurate would you say it's a true reflection of the number of deaths, given that we're measuring various settings, and is it really telling us what's going on in the community?
Well, I would then come back to a question to you. I mean, is that a question of deaths due to COVID directly, or deaths more broadly? If you'd like to answer the second one, that's a different answer.
Yeah, and indeed, if we're measuring what the actual impact on the community, obviously, if the deaths applied to COVID as recorded on death certificates will be very clear. But given your opening comments and how we're judging how the pandemic's spreading more broadly, do you take a view that are we capturing all the information that we need to?
I think the excess deaths due to all cause is a really important statistic. Right. Because in a piece that we have just coming out, we look at 4 different categories of deaths. We look at the deaths directly due to COVID. We control them by those that had, if you like, major comorbidities. We then secondly look at deaths which, if you like, are indirect because of reprioritization of the health service. And in another interview, I referred to my late mother, who in the last couple of years of her life went in and out of hospital a few times for various things. If she hadn't been able to go in, she may have died a little earlier. That, I think we're seeing some evidence of that at the moment. The third category, in the longer term, we won't see for some time, but for example, if there is a reduction in cancer screening, that may see us having deaths over the next few years in that one. And then the final area that we talk about in this piece will be if, and I stress if, we end up with an L-shaped recession as opposed to a V-shape where we come back out quite quickly. An L-shape over a long period of time could lead to a significant number of deaths as a result of people being pushed into poverty or into long-term unemployment. And we know that people in the lowest deciles of income have higher mortality rates, sadly, in our country. And if you increase that, you're likely to see an increase in deaths.
Thank you. Thank you, Chairman.
Thank you. David Jones, please.
Yes, Sir Ian, could you tell us, does the government use any data that is not in the public domain as the basis for its decision making?
Yes, I think it does. And I think that I don't think it is necessarily the case that every piece of data which someone associated with the government should necessarily be in the public domain. I do think that if it is used and referred to, it absolutely must be in the public domain. And that's something that we take incredibly seriously. But I'm not going to, for a minute, I don't think it is the case, and it should be the case, that every piece of data seen by everyone in government necessarily needs to be in the public domain.
If I could come in there, I think this is such an important thing for the work of the Office for Statistics Regulation. So, of course, in the course of doing its business, government, ministers, policymakers get access to a huge amount of information, management information, some of it, real time, some of it maybe not necessarily as clean and as high quality as the things that the ONS and others publish. We don't think that's a problem with that. And ministers have a need to get access to that information to make the judgments they make. But at certain points, the government decides to communicate to the public decisions, proposals, insights. And at that point, if they are drawing in information and quoting it, it should be published. The worst outcome is that numbers are sort of referred to tangentially, or a single number is thrown into a media briefing, and that's not made available in an accessible way to the public. We call that equality of access, and we will always stand up for things which are referred to publicly being available fully publicly. And you may have seen that we've made a couple of interventions along those lines during this pandemic, where we've highlighted where that's not been the case and strongly encouraged the relevant department to make the full information available.
What sort of data is this that is not in the public domain?
Well, let me give the two examples that I have immediately in mind. The first was around universal credit claims, where there were references to the volume. There's been a surge in universal credit claims, very obviously as a result of the economic disruption caused by the pandemic. References to how many claims were being made. So a number was referred to, but the underlying information was not published, and we raised that with the Department for Work and Pensions, and are in the process of agreeing with them a protocol for the publication of this management information, so that it's available to all of us to see. The other example involves Northern Ireland, Department of Health in Northern Ireland, publishing via a tweet and a press statement some of its core daily data around COVID, whilst retaining internally a dashboard. And we said those numbers come from a dashboard. The dashboard should be published as it is in England, Wales, and Scotland. And again, the Department of Health in Northern Ireland has gone ahead and published those data following our intervention, which is very welcome. Those are the kinds of things I'm talking about.
And presumably your concern about that is that not only can your office not scrutinise it properly, but neither can the public nor parliamentarians.
Well, that's exactly right. I mean, I would take out of your sentence my office being able to scrutinise it. To some extent, we're just a bit part player. The key thing here is not that we can scrutinise it; it's that you and the public can scrutinise it. It's available to all.
I wonder, Serene, if I could come back to the issue of the ONS statistics, where there's a lag of 11 days before publication. Is there any way that publication could be brought on more quickly, or maybe could be produced on a more fluid basis rather than at 11-day
very difficult
lags?
I've said at a previous select committee that's already been referred to that in my view, the way to move forward is that we legislate that deaths must be registered within 24 hours of the deaths, and that they must be done so electronically. That would be that's a personal view that we need, because we still receive death certificates through the post. So, my colleagues are doing a fantastic job under great pressure to be able to produce them in the time that they can. And clearly, it wouldn't make a lot of sense, I think, to do it more fluidly, because death certificates arrive, they don't arrive in sequential order to the date of death. They arrive when people send them in. So my view is that my view is strongly that we should get more timely data. And my view in order to do that is we should legislate for the deaths to be registered electronically within 24 hours and enable that to happen.
Thank you.
Thank you, David. Tom Randall, please.
Thank you, Chair. Sir Ian, you're a member of the Scientific Advisory Group, SAGE, and we've talked about the different types of data that's being used. I wondered, when you attend SAGE meetings, what data do you base your advice to government on?
Thank you very much. For clarity, your second statement is the right one. I attend SAGE. I don't think anyone's actually a member of SAGE. Technical point, but I think it's important actually. And the answer to that is that a very, very wide range of data. I mean, I was first invited to attend because ONS had produced some data on the goods which at that time there was some stockpiling of, and we were able to tell for the first time, you know, in the very first week we produced them, that hand sanitizer, for example, was really only available in the north of Scotland. And understanding that and then understanding the prices was important. So it's just an example. There is a very, very wide range of data. Some of it has been based on modeling, so modeling of the epidemic. There is some fantastic scientific experimental data that has been produced on, for example, how the virus spreads in the environment. And I've been incredibly impressed at those meetings, at the depth of the discussion and the breadth of the data. Some of it experimental, some of it biomedical, some of it modeling, and some of it based on the vast experience of some very clever people.
Thank you. And do you feel that all those different data sources can be reconciled to form a single picture to help inform policy decisions?
Well, I think, yes. I mean, I would say that science, in my experience, is almost never black and white. So I absolutely don't think that you could ever get yourself into a position where you say, this is what you should do. Ultimately, politicians such as yourself, who I am in awe of, have a very, very, very difficult job, because the science can provide some evidence and the nuances around it. The politicians need to make the policy. And that, I believe, is what is happening. And there is a very wide range of data. You could look at some experimental data on one thing, but then that has to be tempered by behavioral data on whether people will use it perfectly, for example. And the one thing that I have been incredibly impressed with has been the extent to which there have been really rich discussions which have really taken a multidisciplinary approach and really looked at the nuances and the various nuances that happen. And if I just might add one point, I also think it is very good that officials are there, because, as again, science is almost never black and white. If the scientists have a very detailed and nuanced conversation, those people who are going to be doing some of the policy making, it helps that they understand the nuances.
Thank you. Ed?
Thank you.
Yeah, just to come in on that, I certainly agree that it wouldn't be a sensible ambition, a sensible goal to say, well, let's integrate and reconcile all of these multiple data sets, because the data sets will give different insights and different perspectives. However, what I think is a bit missing at present is making it easy for people to access all the different data sources in one place. We may come on to talk about gaps. That may be a question that you want to explore with us, and I think that's a good question. But in general, I'd say an absence of data is not our problem in this in this pandemic. There's a lot of data, and it's in lots of different places. And people who want to understand it, members of the public who want to understand it, might have to go to multiple websites, might have to go to ONS and the Department of Health and Social Care and National Records Scotland and the Northern Ireland Statistics and Research Agency. And we'd encourage making it easier, making it more accessible for people to find in one place the range of sources. They won't all say the same thing, but they could at least be easy to access in one place.
Thank you, Ed. Ian, you wanted to come back there?
I just wanted to add one thing that I regret not having said in my first response, and that is simply, had you asked me, do I believe that the papers discussed by that committee should be published? And the answer is yes.
Thank you. Karen, you wanted to come in. Karen Smith, thank you.
Yes, thank you, Chair. This may be about the gaps, Ms. Thompson, but I'm interested in the data that could, and in some places is, being collected locally through public health sources. I think that would give a great assurance to many people, particularly those of us living in large cities. So how is there an issue, in your view, about data collection locally by public health experts? And is that an issue, I guess is my question. Is that a gap?
I think the gap lies perhaps less in the data collection than in the data accessibility. So below the level of the nations, England, Wales, Scotland, Northern Ireland, there are data collected. It's just the presentation of those data in a way that's really easy for someone in an area to understand multiple factors in their area. That's much harder because it's not brought together in a way that makes it accessible. There are some really good exceptions. The GLA do a really very strong kind of consolidated output for London, which draws on the same data sets that anybody else could, but they do the work to bring it together and make it accessible. So for me, it's a question of accessibility rather than gaps per se, data not being collected.
Professor Diamond, did you have a view?
I think only to agree with what Ed has just said, to be absolutely honest. Let me just also shout out further GLA data, which I think are absolutely excellent. I do think we should do everything we can to bring data easily into one place where citizens, policymakers can access them easily.
Thank you.
Thank you. John Stevenson, please.
Thank you, Chair. Professor Diamond, the Coronavirus Act allows for any registered medical practitioner to issue a medical certificate stating the cause of death. Do you have any concerns about under-reporting or over-reporting of COVID-19 related deaths?
I think that's a really good question. I don't think it is too much of an issue. And the reason I don't think it is too much of an issue is we have those deaths which are, if you like, have been a positive test for COVID. So we'll take those as given in the main. We also do have a very good system in our country where on the death certificate, people can put a first course or a second course. And so the medical practitioner may say this is due to COVID, even though I don't have a positive test, or it may be that this is a heart attack as a result of COVID. And that first and second, it seems to me, there's likely to be some heterogeneity between medical practitioners as to that two different practitioners might put COVID first or COVID second, but we take either as a COVID death. So I'm not convinced that there is going to be an enormous amount of over-reporting, because practitioners will, I think, have a pretty good idea. Will there be under-reporting? I'm not convinced there'll be a lot of that either. Maybe some practitioners may miss a COVID case, but I'm not convinced that we should feel that there is much under or over reporting here.
Mr. Humferson, any views?
Merely to agree with what Ian has said.
Should there be any concern about these statistics with regards to some people dying with COVID and some people dying because of COVID, or does that not actually matter?
By which you mean people who have a positive test against those people who I've described as, if you like, not dying of COVID, but having an indirect.
Yes.
Well, that's why I believe very strongly that the best thing we should be looking at is all-cause excess deaths. Because we need to remember that every death is causing enormous grief for family and friends, and however and whoever it is, we should be worried about it, and we ought to be looking at both those sources in the long term. But at the end of the day, we need to focus very much on the COVID deaths to get the pandemic down.
You've already mentioned that excess deaths are extremely important. In view of your calculus, how many additional deaths could have been prevented had it not been for the pandemic?
I think that's not a question that I think it is terribly easy to answer. It's certainly not easy to answer until we have much better data. For example, had there not been the pandemic, there might have been quite a bad flu season. I don't know. I don't have that counterfactual. So I think, with respect, that's a question I'm not able to answer with any authority.
And looking ahead, could you project ahead, or is that, again, very difficult to do?
Very, very difficult to do. We are hoping to be able to access some NHS data to be able properly and fully to look at comorbidities. But again, you can't guarantee anything in this area. So very difficult to do.
Mr. Humferson?
Oh, well, I completely agree with that. And, just to come back to where I began, what my role is, what our role at OSR is to make sure that the public has access to trustworthy, high quality information that answers the questions that they have. We are not ourselves people who would do a model which forecasts the future trajectory of a pandemic. But I guess what we want to do is to make sure that information is as open and as reliable as possible for everybody to have access to that kind of information. We wouldn't have a view on it.
Okay, thank you, Chair.
Thank you. David Mundell with a supplementary question, please.
Yes, I mean, we're going to come on, I think, to discuss the differences in Scotland and Northern Ireland, but just specifically, Professor Diamond, on the death certificate issue. I mean, there are different systems of registering deaths in Scotland and Northern Ireland. Are you satisfied that the data that's coming through from those routes is consistent across the UK?
I'm very conscious that we at the ONS work very, very closely on a daily basis with our colleagues at the National Records Scotland. We also provide help to NISRA on cause coding. And look, there are differences. I won't go into them at great length, particularly in Scotland with regard to the fact that we don't get delays from going to a coroner because the death goes to the Procurator Fiscal within 8 days. And that, in many ways, is a help. But so we are aware, though, what has gone to the coroner, and we do work very hard to ensure that we have, as much as possible, comparable data, and I believe we're there.
And would the systems would show up if somehow there was some, if the data wasn't actually comparable, that sort of glitch would become evident to you within a short period?
Yes, I think it would, David, because we are working so closely with our colleagues across the four nations. And clearly there's some differences in death reporting. We report end of week, Scotland reports beginning of week. But overall, we're able to I think, understand the comparability across the four nations pretty well.
Okay, thank you.
If I could just come in on that, from our point of view, the main impact of these differences is in timeliness. That National Records Scotland can publish with a lag of about 4 days, NISRA 6 to 7 days, ONS 11 days, and that's pretty much all driven by timings of registration. I think once you get data for a given time period across, up to say the 1st of May, figures at the cutoff point of the 1st of May will be comparable in terms of death registration. It's just that the figures of the 1st of May will come out more quickly for Scotland and Northern Ireland than they will for England and Wales. It's the lag is the main impact.
Okay, that's very helpful. Thank you.
Thank you. Tom Randall, I think you wanted to come at this point as well.
Yes, thank you, Chair. So Ian, just on this sort of distinction between dying with COVID-19 infection and dying of it. I know the Royal College of Pathologists, for example, have said that the studies suggest that there's a difference between what might be the certified clinical cause of death and then the cause of death determined at a post-mortem examination. And if there is possibly a difference, and given that the data that's being used is sort of driving policy, government policy on this, I just wonder if you could sort of comment on some more on that, and whether you think is there a danger that the underlying data might have any flaws to it?
I completely take your point, Tom, but I'm not sure that the numbers would really change the policy that much, because the great majority of the deaths do have a positive test. So, it is not impossible that following post-mortem, I mean, I take your point that the one might find some changes, but I don't think we're going to find, my personal view is we're not going to find the numbers that are going to change policy in an enormous way.
Thank you.
Thank you very much indeed, Tom. Ronnie Cowan, please.
Thank you very much, Chair. You slightly covered this in the previous question from Mr. Mandel, Sir Ian, but I'm curious as to what's the protocol that pulls together the ONS, the NRS and NISRA to ensure that the decision-making bodies have a complete picture of a pandemic?
Well, I think we do it by working on a daily basis with our colleagues across the three agencies and making sure that, as Ed Humberton had pointed out, there are some differences in the timeliness that people are able to report on, but we work very hard to overcome that and to ensure that right across the four nations we have data that are comparable and timely.
So I hear you saying there's an 11-day lag, but that's a rolling thing. So at any given time, today, could you pull together accurate figures for all of the United Kingdom and do that again tomorrow? Because my concern is that as England and Wales start to ease out of this lockdown, I'm hearing there's an 11-day lag. So would we recognise if the virus was becoming more spread again?
I think there's a very, really good point, and it comes back to one of our earlier responses, which is we do need the daily data that are produced by DHSC, which include now, and they've really improved over the course of this pandemic, and they report all those deaths that are reported by hospitals or care homes on a particular day. And we do need those. Now, there's lags and they're not absolutely complete, but we need them to get the most timely data. The full accurate data, because of the requirement for death registration, we produce weekly for the week before, and we try to get them as quickly as we can. But it's not the case that people, if you like, reports, as I said earlier, sequentially, they tend to come in batches, or they come in at different times. And so the best that we can do is to produce them on a Tuesday for the week previously, which is why we need both the, if you like, the overall ONS data, which provide, if you like, all data together with the daily data from DHSC, which provide all those deaths with a positive test, whether they they are in care homes or in hospitals. We need the two.
But you say you produce them on a Tuesday for the week previously. My concern is that on the Saturday prior to that Tuesday, can you see there's another increase in the number of deaths? And could you report that then? Or do we have to wait for that period of time to realise that maybe a lockdown has increased the number of deaths, the lifting of the lockdown has increased the number of deaths?
I think that there are two answers to that. I mean, the first is if we were seeing something, a trend that was coming, we would be pretty clear to get that to government as quickly as we could.
Right.
But it is quite hard. Having said that, I do think that the new joint biosecurity unit that the Prime Minister announced on Sunday is going to be actually quite key with regard to identifying outbreaks, because outbreaks aren't going to be national, I would suggest. They will be local, and they will require work from Public Health England. They will require, if you like, the use of apps, a whole set of different data which could be used to identify a small outbreak and then to take action. And so I do think that we need data well before deaths if we're going to stop outbreaks. We need data which is coming on people having the virus. And remember that there is quite a period, some weeks, between catching the virus and sadly dying from it. We need that early data, and that's where I see this new unit delivering.
If I could just come in there, the sort of the Saturday risk, Mr. Cowan, that you identify, we know something on the Saturday, why wait until the Tuesday to find it out? The first answer to that is this leading indicator of the daily figures, which are from a different source. The daily figures are effectively from the health systems, England, Wales, Scotland and Northern Ireland, and they, for all the reasons that we've given, they are not as complete as the weekly figures, but they give this leading indicator, and we would know on the Saturday of the previous Friday's figures. So I think in general, this use of the leading indicator ought to mitigate the risk that you've defined, give us a very quick and rapid insight, but a less complete one. I suppose one scenario that where what I've just said wouldn't hold would be if the weekly figures were showing a pattern of deaths which was somehow not being captured into the daily figures. If something was increasing gap between the two, and I think as Ian Diamond said, in those circumstances, we'd definitely expect ONS, National Records Scotland and Israel to be alerting that to their respective governments that there was a pattern in the weekly that wasn't being tracked through to the daily. But that's quite a specific risk factor, I think.
And to both the witnesses, so then you touched upon it there, apps to gather information. It's becoming a new thing. I've got an app on my phone every day. I clock on and say, I've not been tested, but I'm feeling fine. And it gathers information for my local community. How effective do you think those things can be, given the update required to make them accurate?
I'm sorry, I lost the last.
Given the update required for people to actually use these apps.
Yeah, no. Well, I think you've just summed it up beautifully, right? I think that apps are absolutely part of the solution, but they are not the whole solution. And I fear that some of the most vulnerable members of our society will perhaps be the least likely to get the app, whether it is old people, whether it is people from disadvantaged groups. And therefore, we cannot say the app is the total solution. However, the app is a very important part of an ecosystem of data that we need in order to be able to manage the next stage of the pandemic, which critically has to be about reducing the probability of a second peak.
Mr. Humverson?
Well, I think the app is part of a suite of tools. Of course, testing is a really important factor as well. Regular prompt testing, that's got to be part of the picture too.
So testing, tracing, isolating would win over the use of an app.
I think
the two are together.
Yeah.
Okay. Thank you very much.
Thank you, Ronnie. David Mundell, please.
Thank you. Professor Diamond, Inisha, and then Ed, how accurately can we make comparisons within the United Kingdom? I mean, obviously, we've seen at the weekend a view that we would take a different approach in Scotland, Wales, and Northern Ireland than the approach being taken in England. There's also, a general view has formed that the situation in care homes in Scotland is much worse than in other parts of the United Kingdom. Are we able to rely on such comparators?
Well, I think we can look at those comparators very, very carefully. And what you've just described is a real call to make sure that we do have very accurate data for all parts of the United Kingdom. That's why we responded to a request just a very few short weeks ago to stand up a very large survey which will estimate prevalence of the virus in the population and over time the rate of transmission. Phase 1, which is in the field now and produced the estimates I've already described this morning, is for England as a whole. And this was, if you like, to demonstrate that we could set this up and do it at scale. Phase 2, which we will elide into in the next few weeks smoothly, will be UK-wide, will certainly be Scotland, and Wales, I hope, and that will enable us to make regional estimates across those areas that are taking part, and will enable us to make estimates, for example, for inner city areas. We'll design it in such a way as to do that, because I think it is incredibly important that we are tracking the geography of this disease very carefully.
Just want to make a supplementary point, which is about something which has been thrown into really sharp relief by this pandemic. Mr. Mundell, you mentioned care homes and the impact in care homes, and that's of course something across the UK that as a society we're very concerned about, very, very, very worrying that some of our most vulnerable citizens are very exposed to these risks. However, at the start of the pandemic, it was relatively straightforward for the four governments to publish data about what was going on in their health systems, in their NHS. The NHS, is awash with data. There's metrics, there's daily measures, there's situation reports, and much of that has rightly made its way into the public domain, consistent with all the principles that I've outlined earlier. That's never been the case, that the social care sector has been so thoroughly monitored, measured, tracked. And we, as the Office for Statistics Regulation, have been arguing for some time that there's no parity of measurement between the health and the social care sector. There's much more measurement in the healthcare sector than there is in the social care sector. As we've had this, what's described as the epidemic in care homes emerging, I think that issue that we've had to stand up quickly, measurement in the care home sector, has really come through. And I hope that we, as a society and as governments, take heed of that and realise that we should have as much insight into what's happening to people who are receiving social care as people who are receiving healthcare. I think it's really thrown into relief by this pandemic, that disparity of measurement.
I think, Ed, that's a very, very important point, and I hope overall across the whole of the United Kingdom that's something that is taken forward, that parity in terms of social care and healthcare. Can I just ask one further question of yourself and Professor Diamond, in basis of what you said in opening remarks, and that was that essentially there were three pandemics: a pandemic that was in the community, a pandemic that was in care homes, and a pandemic that was in hospitals in sense of the infection capability. How then, how is that taken into account in the presentation of data, so as to ensure, for example, that the community aspect is not, for example, distorted by the fact that there might be a predominance of care homes or a very large hospital in a particular geography?
Was that to me first or to
yes? Well, you first.
Look,
I think you raised it in the initial.
Yeah, no. I think it's the right question, and it is always an issue in geographies. If you have a large hospital, it doesn't matter whether there's a pandemic or not. But with this particular pandemic, I think there is an enormous amount of work being done to understand nosocomial infection and some reasonably tight definitions when it comes to death through work that Callum Semple at the University of Liverpool has done, which enables us to understand, if you like, something about nosocomial infection. But there is an enormous amount of work still to do in that area. There is an enormous amount of work still to do in understanding the transmission and the mechanisms of transmission in care homes. And ONS is currently helping to design a study in care homes, which will be led by University College London, which will enable us to understand much more about transmission in those areas.
Just to add to that, several of you have asked about regional, local, sort of place-based patterns of understanding the pandemic, and I think that becomes more important. I think Professor Diamond's take on this as being three epidemics rolled into one is right, but of course it's also epidemics in places, in particular localities, and I think that's why there's granular information and access to it, which I think has come up several times, making it easy for people to access what's happening at a local level. I think that becomes more and more important as we move into the next phases of this experience.
Thank you.
Just quickly, Ian, do you want to say something there?
Yeah, very quickly, just to come back to David Mundell, and just one further point, if I just may. We just need also to recognise that these three epidemics that I've talked about are not mutually exclusive. There is an intersection, an important intersection in the Venn diagram, so we still need to think of the overall epidemic as well, because of the way in which there is seeding into different communities that we need to worry about.
Thank you very much. Karen Smith, you wanted to come in at the moment.
I think that was going to be my question. I spent 20 years working for the NHS feeding the beast with data. So Ed, I totally accept what you've said there about the parity of social care. So my point was going to be then, given what you've said, we must have parity of that data from the community that has to be collected in a way that involves local people, so that we can in fact trace that intersection. That surely must be the push now we need on this accurate data from the community place.
I couldn't agree more. And certainly our survey that I've described earlier, that we're doing in partnership with the University of Oxford, the Wellcome Trust, is certainly gaining community level estimates and engaging very many members of the community in it. I also believe that we need to engage the community in if you like, being prepared to say, I am going to tell you I've got the symptoms, because early identification, it seems to me, of outbreaks over the next while is going to be incredibly important so that we can act on them. And that requires, in many ways, people saying, hold it, I've got some symptoms, I need to get tested, and I need to let someone know. And so to me, I think my observation, I've talked earlier about the data we've collected on adherence to the government's lockdowns. And what we saw was a nation that absolutely bought into the lockdown and adhered incredibly well and has supported people. We find in our survey data that people are saying that they are supporting other members of their community, for example. So far so good. The next stage has to, in my view, maintain that community spirit, because the way of getting on top of outbreaks won't come from death data. It has to come from people when they get symptoms, really recognizing it. And we have to have a system to come back to the point that was made earlier about testing and tracking. We need to then get in and test very quickly.
But in my experience, that's not just the community spirit, is it, Professor? It is the trust in giving over that data from individuals in different communities, perhaps not always to an app, but perhaps to a known individual, trusted community or public health or GPs. That's where
I couldn't agree more.
Okay.
Yeah, I couldn't agree more. And I think it has been incredibly important for me in that all the work we have done, however we've collected it, all our data collections have been through our ethics committees, independent ethics committees, and that to me is incredibly important, because if we lose that trust, the trust that this is anonymous, whatever, then we're lost. So trust is absolutely critical, and therefore that the need to do things ethically and properly is also absolutely a sine qua non of everything we do at the Office for National Statistics.
Ed, you wanted to come in.
Two issues just to follow up on that. One is, I think this point about people feeling confident, trusting, feeling that they're providing their own personal data to a trustworthy source. This is where the ONS's household survey is so important, because we know that the ONS is regarded as a very trustworthy processor of people's data, seen as being, rightly seen as being independent, and I think we should harness that. It's what that survey that Professor Diamond has described is one of the best ways to get to the community level of insight that we were talking about. But there are other ways as well. And just on this point about people having symptoms, there's a really, really good bit of analysis done by NHS Digital of calls to NHS 111 when people are reporting, and they're triaged through NHS 111 about their symptoms. And they publish, NHS Digital publish some really powerful graphs and summaries of the data, which show patterns of not just nationally but regionally, volume calls and how quickly that volume has tailed off as the pandemic has progressed. So that's a source which tells us what's going on in the community without necessarily needing to use the phrase to feed the beast. We get more data collections. So I think it's that's a really good a good source.
Thank you.
Thank you. David Jones, please.
Thank you, Chairman. Ed, it was reported a couple of weeks ago that two Welsh health boards, my local one here, Betsy Cadwallader, and Hywel Dda in southwest Wales, had been underreporting coronavirus-related deaths. The Welsh government initially said that this was because the protocol for reporting deaths had not been embedded consistently, but the Public Accounts Committee of the Welsh Assembly reported earlier this week that it was quite simply that the two boards in question were using the wrong software. Could you tell me how confident you are in the consistency and quality of reporting by other health boards in Wales?
Well, I've not done any specific work on the reporting of health boards, but I can speak from general experience, and that is that any administrative data system has this kind of risk in it, that the people who are compiling the reports either don't quite understand what they should be doing, or they submit the form in the wrong way, or that there's some other bureaucratic blockage, which means that the data are incomplete. And it's worth saying about these cases that they were identified because Public Health Wales started to publish the figures that they were receiving, not just at the national Wales level, but also regionally. And immediately what happened was that Betsy Cadwallader Health Board said, those don't look like our figures. They look like they're light. And that triggered the investigation. And I think the point about that is, well, 2 points about it. One is it really goes to the theme of the whole session that we've been talking about, which is the need for something which goes beyond the national level. But secondly, that point about actually publishing data and letting people see it, and people saying, well, that doesn't look quite right. So in terms of how confident I am, I can think that within Wales, some really sensible steps have been taken. There's now a requirement for the health boards to provide specific assurance on the completeness of their data. The chief statistician in the Welsh Government now has an oversight role, which he didn't have before. And there's much more weekly sort of confrontation of the data. In other words, the health board sitting around looking at their data, looking at each other's data and saying, does anything look surprising? More generally, we know that administrative data systems have these problems. And I think that the experience in Wales should be quite salutary, not just in Wales, but elsewhere across the UK, to be very, very willing to examine those administrative data to make sure this sort of issue is not recurring.
And Sir, how much of a risk do instances such as this of underreporting present to the completeness of the data? And what are the risks of the government making decisions based upon erroneous data such as this?
Yeah, no. I mean, I think it's, as Humferson has just said, what people always, sometimes people forget that administrative data collected for administrative purposes can be subject to error. Sometimes people think, oh, it's administrative, so it's fantastic. Well, it is fantastic, but it can be subject to error. And that is why it's incredibly important that we are at all times triangulating against other sources of data. Or, I mean, one of the things about good statisticians is that they're always just a little skeptical of the data, and they're looking for, I personally have always said to people, I was privileged to teach many great people in my life as an academic, and I always said that, don't trust the data, absolutely look for errors. And that is something that we always need to continue to do. But of course, in this case, the data are supported by death certificates across most of the country. And so I think we should be worried. We should continue to do everything we can to make sure that we're checking in different ways the data. But I do believe that these are isolated incidents.
Taking those two isolated incidents, what potentially could have been the impact of those errors upon government decision more generally?
Had they not, I mean, at the end of the day, we're talking about this because they were identified. But you might, well, there are all kinds of things you might have thought about different geographies, but I think what you might have done is start to ask yourself what is going on in an area which has a rather different pattern. That would then ask you to go and look at that. I hope you wouldn't rush into policy. You'd go and say, what is it that's going on? That would help you either to understand something particular about that area, or to identify that you had a problem. So I hope that you would be looking at patterns and you would be asking questions all the time.
Thank you.
Thank you, David. Just with me now for the moment. And I'm very conscious when we talk of these statistics of those who've sadly passed away with COVID-19, that we're talking about individual families and friends who are grieving for loved ones. with these statistics. But could I ask, Sir Ian, does the UK have the highest coronavirus death toll in Europe?
I'm not prepared to say that at this time. I do think that we have very good data in the UK, and I do think that there is no doubt that we are, if you like, at the higher level for deaths. I have no problem about saying that. I am, because of the great difficulty in understanding exactly whether we're comparing apples with apples or apples with pears, I'm not prepared to say that the UK has the highest. So, for example, if we look at the comparison with Italy, the most recent adjustment made in Italy only took us up to the end of March. We are much further on, and the Italian adjustment was using tax records. So there are very, very different data collection strategies in different countries. It will be some time, because of the way that other countries report, that I'm able to give an authoritative answer to that question.
And that's helpful in outlining some of the difficulties that there are in comparing statistics, but also perhaps in the use of language of how it's been described, the difference between the toll and the rate, for example. Do you have any comments to make on that?
Well, I think you would expect a bigger country to have more deaths given a similar rate. I mean, that's not rocket science. The bottom line is we need to get our definitions absolutely right before you can make realistic comparisons. I do believe, because of the difference in size, that you are much better off using some indicator of rates, because then you can actually see what's going on. But that does require that you're comparing apples with apples.
Thank you, Sir Ian.
I can just come in on that.
Yes, indeed, please, Ed.
In a way, this issue is at a sort of a macro level, the same issue that we were talking about with regards to administrative data in Wales or in other parts of the UK. I said that any administrative data system, you need to understand the way in which the data are compiled and what they say and what they in other parts of the UK. It's even more of a challenge understanding how to compare figures across administrative systems. And for those reasons, I think it's really very difficult,
so I wonder,
perhaps pointless, to create a league table. However, on the other hand, I do think it's worth looking at the international experience very carefully and seeing what we can glean, not maybe at the headline number level, not just these big numbers, whose number is bigger than who else's number, but in terms of rates, in terms of practices, in terms of approaches, and indeed in terms of how things are reported and recorded. I think there's really rich lessons to learn there. But I think the single number league table, this is not a very fruitful use of our time.
No, indeed. And so with that answer in mind, as the regulator, are you satisfied with the way in which the government has used international comparisons during the daily briefing? I know it's changed recently, but initially it was quite focused upon that international comparison. Ed?
We welcome the change which has come in the last few days to remove those simple comparisons.
Okay, and I just wondered, Sir Ian, as the official advisor on statistics to the government, what advice did you give them on the use of international comparators? Well,
we have a couple of quite senior ONS statisticians who are embedded within both Number 10 communications, and they have, I know, been working very hard to help with the presentation of data.
Thank you. David Mundell, I think you had a supplementary question on this section, please. David.
Yes,
thank you.
Sorry, sorry, and Ed, I mean, I heard, Ed, what you said, and I fully appreciate that in terms of the effort to go into the legal. So people are going to want to make comparisons. I think you just can't get round that. There will be a wish to do so. So particularly, Professor Diamond, could you just expand on some of the issues that mean that we are comparing apples
Sure.
With pears? Because often it is again this sort of generic statement. Oh, well, it's all different. I mean, what actually what are the substantive differences that mean that these comparisons are not readily made?
Thank you for giving me the opportunity to answer that question. And could I just start by saying I think we should be trying to make comparisons, but equally in making comparisons, we need to really understand the challenges. Let's just start with age. We know that above all, when it comes to deaths, this is a disease which really impacts the elderly members of society. So if your population has a radically different age structure, then one needs to do something about controlling for that. Ireland, for example, has a much younger age structure than some other parts of Europe. Secondly, we know from ONS data that this is a pandemic which started in London, kept mainly in the inner cities, takes much longer to move through rural areas. Therefore, you need to know something about the degree of urbanization, the degree to which people are living close together, because it seems that there is some transmission there. These are areas that you really need to take into account, as well as the points that we've already talked about, which are about making sure that the recording is comparative. I've mentioned already that the Italian data is based on a different basis to the UK data. They made an adjustment a little while ago, which used some evidence from tax records and went to the end of March. They will keep updating as we go forward. Some of the German work is based on a sample, and again, they will keep updating over time. So firstly, we need to make sure that we are all comparing the same thing. For example, the Belgians looked at very high rates for a while, but they were one of the places that was reporting social care as well as hospitals. Mm. So there's a really, if you like, there's no other way to do it but being very, very careful to make sure that you are absolutely all the deaths are being compared to the right timeline and to the right degree of coverage. But then you also need to understand the things which impact on the disease, for example, age, for example, degree of urbanization. And you need, I would argue, to model in a way which controls for those before you start to make real comparisons.
Yeah. Thank you.
Thank you very much, David. We go now to Rachel Hopkins, please. If you just check the mute on microphones, thank you. Rachel, if you could.
No, sorry. Multiple screens open. Thank you. Just probing further on our care homes, does your data show a more worrying pattern of COVID-19 deaths in care homes and other settings?
Well, it most certainly shows that there has been a really high degree of COVID in a relatively high proportion of care homes, no question. And we've also shown in some work that we published earlier this week, that care home workers have a higher mortality than other healthcare workers. So there is clearly a major challenge that the disease, when it comes in, can take hold right across a care home. We need to know more about the extent to which care home workers moving between care homes are both a worry, and that's why we are supporting the development of a study into transmission in care homes, which will start in the next couple of weeks.
Is talking of the workers in care homes, is there any initial information data you have that could start to explain this?
No, we don't. I mean, I'm afraid that what we've got at the moment is very much, sadly, the evidence of the death statistics. Anything else I would say would be mere speculation. That's why we're doing a study.
Okay. In terms of the data that ONS collects in other sectors, are there some that could be used as a proxy for deaths in care homes that might help plan an approach to bringing them under control?
Not really. I mean, I think we need to understand the mechanism for transmission. Now, we also need to recognise that it's not so much is there studies that could be used, but we can say things about transmission. We know that a lot of transmission will be through people touching and then touching their face. So we need to think very carefully about cleaning. We need to think very carefully about social distancing, all kinds of things that are incredibly important, and we need to learn as much as we can internationally. But equally, for us at ONS, we are working with the experts at University College London and helping them to design a study which I hope will answer many of the questions that you are asking.
And just pressing a little bit further about the quality of data around COVID-19 deaths in care homes that we did talk a little bit about earlier. Just, are you confident in the source data for the official mortality statistics for care homes?
Yeah. We put a lot of work into that because you need to, because some people sadly will die in care homes. Other people will go to hospital and die there. And a lot of work has been put by the ONS Health and Life Events team into ensuring that we get a true picture of the deaths in the care homes.
Okay, thanks. Can I just ask a question to Ed, please? In your recent letter to this committee, you said the data on social care was inadequate compared to data on healthcare. Could you just explain that a bit more and tell us what you plan to do about it?
In terms of what we plan to do about it, we will continue to be very strong advocates for much more comprehensive measurement of adult social care. And I say adult social care because it's really important that when we came to this whole issue, we weren't thinking about care homes versus hospitals. We were thinking of social care versus healthcare. And of course, a lot of social care takes place in the home, not in a care home setting, but in people's homes. They receive domiciliary visits and so on. So what we will do about it is continue to press the governments of the UK. It's not just Department of Health and Social Care for England, it's across the UK, to recognise this issue and to address it. I also think that Professor Diamond and his colleagues at the Office for National Statistics can play a really big role here, because to the extent that social care is received not just in a setting called a care home, but in people's own homes, this is a household issue, and the people who've got the best way of understanding what's going on in the household sector are actually the ONS. They do household surveys with real expertise and real insight, and therefore I think that we would look to ONS to play a bigger role here. In terms of what we mean by it, it's that there are lots of very significant questions about social care that are gaps, which are not gaps for healthcare. Things like outcomes, things like actually the comprehensive funding. We know how much funding comes through local authorities, but less which is paid for privately. Things like unmet need. Now, those are all general questions. Our concern was not triggered by the pandemic. It predated the pandemic for some time. We thought that those questions were gaps. I think my point is that what the pandemic really shows is the approach to measurement in the social care sector has been lacking, and that's then got exposed by this sudden outbreak of what Professor Diamond has described very accurately as a pandemic in care homes. But it's a bigger issue than that.
Thank you.
Ian, you wanted to come in there.
Just very quickly, and the other challenge, on top of everything that I agree that Ed has just said, the other challenge is the breadth of the sector. So you have a number of very big multi-home chains, but equally the biggest number is in terms of small, if you like, single homes, and actually getting that breadth and understanding that breadth incredibly challenging, something that we are really committed to doing.
Thank you.
Thank you very much. David Mundell, I believe now.
Ian and Ed, I mean, in the previous questions, we talked about the differences between the nations of the United Kingdom. I mean, within England itself, there's now the suggestion that the Northwest is the most affected area. Is that something that can again be vouched, as we were talking about before, and indeed the sort of movement of the sort of epicenter of the pandemic across the United Kingdom? I mean, I think from your previous answers, I mean, you were suggesting that that is something that's capable of being tracked.
Yes, no, it's something that's capable of being tracked. You can track it both from hospital admissions as well as from the work we will be doing. But again, in many ways, it's not surprising. An epidemic like this start in the capital city and then move into the other bigger cities. London was followed by the West Midlands. We're now into the Northwest and to extent the Northeast. And we need to recognise that has happened and to monitor at a regional level so that we can really target resource in the right way.
And how does the information or the data that you're putting forward in that regard, affect the decision in relation to the lockdown arrangements? I mean, from your perspective, is that just the data, and then ultimately lockdown arrangements are a political decision?
I think the lockdown decisions are essentially political, but they must be informed by data. But informed is the right way, and I think what we have done rightly, in my view, is to, if you like, take a very national approach. As we move to the next stage, as I've already indicated a number of times, it seems to me that what we need to do is stop a second peak, and that might be with a much more, if you like, localized strategies, and we need therefore to be able to have the data to enable the policy to be made.
So you would envisage, I mean, within England and indeed within Scotland or Wales, Northern Ireland, that there would be a more localized approach, not just that there would be a geographic approach of, say, taking Scotland and doing something different there, but that you would take Glasgow and do something different there. Is that?
Or you just might take a school.
Right, a particular school.
I think, if we look at, South Korea just recently identified an outbreak in a small nightclub area in Seoul and have moved to it. If we can get on top of this, then we need to be in a position where we identify early small outbreaks and act on them. And the range of things that you can do will vary on the context and on the size.
Okay. Thank you.
Thank you. Karen Smith with a supplementary, and then we'll be on to Ronnie.
Thank you, Chair. And it's on that localised point, which I think we have covered earlier, with the need to have data to inform that, given that this is a community issue as well as a care home and hospital issue. And I wanted to draw the committee's attention and the great figures in your data. Figure 6 from last week is the classification of urban and urban-rural classification, very strongly showing the rates of deaths in cities, which David has alluded to. Obviously that would include Glasgow and Edinburgh, but largely this will be English cities. When you talk about a small school, but at the moment we're not even at the stage of a judgment of a city like I represent in Bristol to be able to control the data input and the reaction and the testing and tracing of our own citizens in a city the size of Bristol, let alone the size of a small school in Bristol. So how is the progress to be made on understanding and managing this virus now, which we know is in the community, in our cities? How do we get from where we are to where you are talking about, for examples in Korea?
Yeah, no. And I mean, if I return to something I said earlier when I talked about the Prime Minister's announcement of a joint biosecurity unit, and it seems to me that that has a really important role in harnessing a large number of data sources in a way that we haven't done so far. I've mentioned apps, we've talked about tracking and tracing. One can also, for example, look at wastewater. What one can get, we talked in one of your previous interjections, we talked about people, if you like, reporting and community awareness. These are things that I think we really do need to work on, and we'll be using. And Ed Humphrey also mentioned your 111. There's a wide range of data sources, in my view, that we should be using, and we need to really work hard over the next while to be able to identify outbreaks as early as we can, and then to act. And there is no one-size-fits-all strategy. We need a flexible, I would submit, set of strategies. And when we make a strategy, we need to monitor and evaluate it so we can learn from it as we move forward.
Thank you. And I'm afraid I'm not up to speed on this new biosecurity unit. Is that what it is going to do? Is it now finally going to link with our local expertise and knowledge and build that community trust? Do you know?
I'm afraid I'm not able to answer that authoritatively.
Okay, thank you.
I wonder if I might refer to something which I haven't mentioned much so far, which is the intervention we made as an authority earlier this week about testing, meeting the government's testing targets. One of the things we said in that intervention was that the testing targets were could be defined more clearly, so people understood what actually a test is. Is it a person being tested? Is it a test being sent out? Is it a test being completed? One of the other things we said there, and this second piece has received less attention, but I think is equally important, is actually be really good not just to talk about a national number of tests, but the regional pattern of tests and the regional pattern of test results, which I think absolutely gets to the heart of Karen Smith's question, which is, these big national numbers are useful if you're interested in at the England level or the UK level, but lots of people and lots of decision makers are interested in the subnational picture. And so publishing as much that can equip them with information as possible is really, really important. And so we did bring that point out as well when we talked about testing.
Thank you, because crucially, the sub-regional level is the only way, and I think we alluded to this earlier, that we are going to control this disease. No question. We are not going to control it on a UK or even an England-wide basis. We are only going to control it from your example earlier of a small school within and we are talking about cities largely.
I completely agree.
Thank you.
Thank you very much indeed, Karen. Ronnie, please.
Thank you, Chairman. So, what does your data tell us about the main demographics factors that might affect the risk of dying or even contracting the coronavirus?
Yeah, we've published a number of pieces on this in the last couple of weeks. And as I said earlier, age is the key factor here. The older you are, the greater the risk. Secondly, we know that those people who have comorbidities have some real extra risks. And then thirdly, we have shown that people from Black and minority ethnic backgrounds, that people in more deprived neighborhoods and people with in more low paid jobs have higher risks. What we have been trying to do is really to look at the explanations for this, and that is work that is ongoing.
So what do you mean the explanations for this? Is that not quite clear? People who are living in more deprived areas, people who are doing less well-paid jobs like care workers, you know, people who not so many months ago were talking of as unskilled workers. These are the people at the front line who are then travelling back to their own communities, which are some of the most deprived communities, and therefore that's why the number's going to be higher there.
Well, that would be your speculation. What we, for example, have not saying that. But what we have not shown, for example, is that there, at no stage have we shown there is something genetic, for example, that we've looked for and continue to look for social and economic factors which are influencing the course of the epidemic. I would have to say that that all of these are dwarfed by age, which is the key demographic. And the evidence seems to be that men have higher risks than women.
Okay, so take my constituency of Inverclyde. It's got higher deprivation, it's got comorbidity, and it's got an ageing population. So not surprisingly, the death rate in Inverclyde is 3 times the national average for Scotland. So when this is over, and I finally get my hands on a heat map which breaks down Inverclyde into areas, am I right in thinking that the areas which have suffered the most infections and the most deaths are going to be the most deprived areas in my community?
Well, I think, sadly, I would suspect that will be the case, because we know from work by many, many scholars over many years that there is a steep gradient in our country between levels of deprivation and all measures of health and mortality. And what we are seeing with COVID is this is no different to very many other illnesses, causes of death, causes of ill health that we have in our society. And I think the whole area of health inequalities is something that people have worked on. And I know your colleagues at the University of Glasgow and at the Medical Research Council Sociology Unit there have put an enormous amount of effort into understanding those health inequalities. And I think there is much for us still to do.
So are those figures available now, or am I going to have to wait until next year to see a breakdown of that?
Well,
what level?
We have not done that for Scotland. We have done it for parts of England. That's what we've produced in the papers that we have produced in the last couple of weeks, and we will continue to produce over the next little while. So I would hope that you're not going to have to wait an enormous length of time. There is an enormous amount of work going on, and we will continue to bring out the regular papers that we have been over the last few weeks.
So when you say you've not done that for Scotland, is that because that's not your role? Is that the job of the NRS?
NRS would do that. We are always able and willing to help, but that is the role of the NRS.
Okay, and so why are we? You have got figures about the effect this virus is having on ethnic groups, on BAME.
Sure.
Why is that not being? Why is that not part of the daily figures from the UK government?
Well, we produce our daily figures based on death registrations, and death certificates do not include ethnicity. So what we do is we link the death certificate with, for example, census data to understand what the ethnicity is, and then we produce the reports that we do. You couldn't do that in the kind of time that is available wanting to produce results.
I see. Okay.
I can just come in on that.
I noticed
there are some figures produced by the NHS on mortality by ethnicity. NHS England, for example, publish a set of figures on mortality by ethnicity. And it's those figures that the Institute for Fiscal Studies used to do their analysis of mortality risk by ethnicity. So those figures are available, and they're promptly available. They're not complete because they're based on the hospital setting, but they provide quick insight into this very particular aspect of this issue, worrying aspect of this issue.
Okay, thank you very much. I noticed on hot heels of the Prime Minister lifting the lockdown slightly in England and Wales, or sorry, in England, to allow construction workers to get back on site, that the data released by the ONS on Monday shows that men in jobs like construction and transport were more likely to die of the coronavirus than the general population. How significant is this difference, and how should the government use this information when deciding who should go to work?
I think it's important, and what I think it says to us is that government needs to work with the various trade authorities to ensure that returns to work can be done in a safe way.
But you specifically mentioned construction in your figures.
Yeah, no, and I think it is important that I'm conscious, for example, that the Department for Business and Industrial Strategy have produced a set of guidelines for different industries to ensure safe workplaces. And certainly the Office of National Statistics, when we start to go back from working from home, one of the things we are worrying and thinking about is ensuring safe workplaces. So I think, it is, for me, it is a question of the need to work with the people who are experts in those particular fields to say, well, how is it that we can ensure a safe workplace?
Okay, can just very, very briefly and finally, can I ask you, why was that question asked of men? Surely there are women working in construction and women working in transport as well?
There certainly are. I will just need to check on that, but these data are based on deaths, and I would suggest that the numbers are too small to make statistically meaningful results. But please, could I be permitted just to check on that?
Sure. Of course. Okay, thank you very much.
Thank you, Ronnie. Just as a follow-up from some of the figures, or at least the source of figures that Ronnie's quoted, the Monday's data shows that social care workers are significantly more likely to have died with COVID-19 than the general population, unlike their counterparts in other healthcare settings who appear from that data not more likely to have died. Is that a correct interpretation? And could you explain that further, perhaps? Ian?
I don't have a problem with the interpretation. I think that to me, a result like that is the starting point for further investigation. That's why there is work going to go on care homes. It is not a finished point where I'm prepared or able to give you an authoritative answer.
Thank you very much. We're going to briefly change topic to the question of the matter of the census with Jackie Doyle-Price, please.
Thank you, Chairman. Yes, business as usual. This is a big year, obviously, for the ONS ahead of the census next year. Can you just give us an update on preparations for that, recognising that you've also got a lot else on?
No. We will be running the census for England and Wales and helping our colleagues in Northern Ireland with theirs. They use similar procurement. And we did a test in the autumn, which went very well. Clearly some lessons learnt, and we have I think a very strong lessons learnt paper, and we will be working hard over the next year to move forward to what I think will be a very, very good census. Now, has the current pandemic caused us challenges? Of course it's caused us some challenges. Have we taken account not only the risks of the current pandemic, but the risks of a second peak, were there to be one? We have a number of risks that we are controlling for. But at the moment, I am confident that we can do a really, really good census, and that we can continue to do a really good census, even having to control for other things that may happen with this pandemic in the future.
Well, that's good to hear. Thank you.
Just one word that we use an enormous amount in this: confident, but not complacent.
Oh, very good. That's a watchword for everyone, I think. We were told last year that, well, the Women's Inequalities Committee was told specifically that the legislation would have to be passed by April 2020 in order for it to be on track. That timetable clearly slipped, but obviously we commenced that now. But how has that affected preparation?
We have managed to be agile to enable us to manage the small slip that we've had, and we are just about on track.
Good. And obviously, I mean, the current pandemic has affected preparations, but you're obviously preparing for, as you just said earlier, in case that there is another wave. But what other steps are you taking to work around that, given the other demands?
Well, we have been very clear to maintain a strong team, and I mean, we do have a really, really strong team. And some of the people working on, for example, the methodology, this is their third census, and that's you rarely have countries with that kind of experience. And so we know what we're doing. We have everything on track, but at the same time, we have a number of gateways that we are going to go through, and we're not going to get ourselves into a position where we're saying how clever we are and everything's fine. We're going to get independent people that come and really, drill down and make sure that we continue to be on track. And as I said, we have a number of strategies we can use with our coverage survey and with our administrative data if we have hiccups between now and the new year. I do think, we need to recognise that our censuses across the UK they have some of the best under-enumeration strategies. I would say this, but they're the best under-enumeration strategies in the world, and that means it's one of the reasons why I remain confident that we can deliver a census.
Excellent. Ed, do you have anything to add to that?
I need to say that as well as being the regulator of government departments, we're also the regulator of Professor Diamond and his colleagues at the ONS, and we're keeping a close eye on the census. Although the particular thing that we care about in terms of the census is at the end of this process, the data are collected from all the households and all the people. That's then crystallized into information about the nature of society. How many people live in the country, where they live, what their lives are like. And it's that we want to see being the highest possible quality. The completion of the census as a program is an absolutely essential, fundamental first step there. But we want to assess and review the outcome of presenting back to all the people who complete their census forms in 2021, presenting back to them the picture of the society they live in.
Is there a pattern of any changes in people's compliance with completing the census? I mean, if we look at, I asked the question because obviously we're seeing over time a decrease in people participating in the electoral system, for example, and that's partly because of a decline in deference. And there was certainly, when I can recall my first recollection of census, this was very much seen as a civic obligation, and that's kind of diminished now. So do we see any declining levels of compliance with completing?
Well, certainly, I mean, if we go back historically, we assumed that the census was a complete count. I think perhaps my personal view is that that was perhaps a heroic assumption with the benefit of hindsight. Since 1991, we've recognized that there are particular groups, often young single men between 18 and 30, a particular group who tend not to fill in their census forms as assiduously as we would like them to do. And so I also feel that we need to recognize that in some of the communities we've talked about before, increasingly some of our newer communities, we need to work hard to impress on them the benefits of being part of the census. And that's why one of the lessons learnt from our test was the real need to up our community engagement, particularly amongst some of our newer communities in the UK. And that's something that we are really actively taking forward. So it's a question of really working with communities to impress on them of the not just the civic duty, but the kind of what's in it for you about this, but at the same time having very, very strong methods for estimating under enumeration and allocating that in the right places.
Just to add a supplementary thought, the pandemic obviously has been a terrible experience for our society, but one of its side effects, or very direct effects, is to remind us all that we have civic obligations to one another, to our communities, to our families, to people that we work with. And I just wonder whether you talked about a decline in, or regarding the census as a civic obligation and speculating as to whether that's a decline. Maybe civic obligation is sort of coming back as a fundamental part of what it means to live in our society, and that may play out in the census responses in 2021. Let's hope so.
Well, a very uplifting end message. Thank you very much. Thank you.
Thank you, Jackie, and hopefully not to depress that uplifting end message, if I end with one of my own, which is to thank both of our witnesses this morning. Particularly grateful for the contribution that you are making, and grateful also for an indication of the work that you intend to carry out, and any work that will help suppress a second peak, and particularly a greater focus on that demographic information. There are some areas which you may wish to write to the committee, certainly if there are any outstanding questions, and we'd be very grateful for you to do that in your time. Can I also thank all colleagues and staff, particularly broadcasting staff, who are working very hard to support all of our parliamentary business. But can I thank everybody very much indeed for their virtual attendance this morning. Order, cheers. Order.
13th of May 2020. Public Administration and Constitutional Affairs Select Committee virtual meeting the 13th of May 2020. Public Administration and Constitutional Affairs Select Committee virtual meeting the 13th of May 2020. Public Administration and Constitutional Affairs Select Committee virtual meeting the 13th of May 2020. Public Administration and Constitutional Affairs